Good evening. Warm welcome to all the delegates who have joined us today for Scale Masterclass series. We are having yet another pioneer speaker and a senior embryologist in the field. He is well known among the field of embryology all over India. So today the topic is going to be navigating PGT in today's IVF lab. Next slide. We all know that we have launched the Scale Fellowship Program. We have 1 year fellowship program in clinical embryology and also ART. It's going to be a fully hands-on and rigorous academic program with mentors in the field. So it'll be definitely beneficial. So we once again would like to inform about the same. It gives me immense pleasure to introduce Dr. Sarabpreet Singh. He's a MD from prestigious AIMS, IFS and ESHRE certified senior clinical embryologist. He is heading the clinical embryology and andrology unit at Artemis Health Institute since 2009. He's the chair of clinical embryology in IFS 2024 to 2026. He's very active in academics and contributes a lot to IFS. He's a director at the Fertilis Academy. His key areas of interest include cryobiology and male infertility. He has won several awards. Few of them include Champion of ISAR Award, Award for the Best Convener Special Interest Group Clinical Embryology at Fertivision 2019, Best SIG in Applied Genetics Award at Fertivision, IFS Achiever Award at Fertivision 2022, IFS Appreciation Award at Fertivision 2023. So it's indeed a great pleasure and honor, especially who has more interest in genetics. And today he is going to talk about navigating PGTA in our IVF lab, which can be, it's a very, very vast topic. So he has consented to do this at 2 segments. So we have the, basics, the indications of PGT, then what could be the platforms of testing, what are the, what are the pitfalls of testing, what are the lab preparedness that is required for PGTA, the workflow in the lab, and so much and so forth with the current ART regulations. A lot of things are there to discuss about this topic. So we are going to do it in part A and part B. Over to you, Dr. Sarabpreet. We're all waiting to hear from you, and we request all the delegates to be as interactive as possible. Thank you so much.
Yeah, thank you so much for the kind introduction and the opportunity. Let me share my slides. Can you see the slides?
No.
Not yet, sir.
Am I the co-host, right?
Yeah.
Yes, yes.
Please see the slides. Give me 1 second. Yes, yeah.
Yes, we are able to see.
Okay. So I think we're in a good position now. So I'm getting these notifications every now and then to admit people. So I think the other host can take care of this, right?
Yeah, we will take care. Don't worry about it. Yeah.
Okay, so I met Dr. Vasundara in one of the conference meetings in Delhi, and she invited me to speak on this topic. Thank you so much, Dr. Vasundara. Indeed, a pleasure. So the topic for the day is genetics meets embryology, navigating PGT in today's IVF lab. So as she's introduced me, so I'll move on to the next slide. So I would be talking on these topics today because Dr. Vasundara gave me an extensive list of topics which I thought could take around 1.5 hours. So I didn't want to carry it that long, and it's good to break it into 2 parts. So we will be talking about the basic introduction, then the workflow of PGT, then we'll talk about the essentials of PGT program in context of the documentation, the infrastructure, the legal requirements, and the in the we'll also discuss the tiny details like media consumables and what extra is required in PGT program. And then we'll go on to the techniques of biopsy and tubing which I thought I'll cover in the second session, but I brought it to the first session, and then I'll briefly introduce the reproductive genetics. And in the next session, we will definitely explore details of fine details of PGTA, PGTM, and PGTSR, and chiefly focusing on PGTA. So with this, I want to move on to my first slide. As you all know, the first IVF was baby was Louis Brown she was born on 25th July 1978. Until then, the success rates have considerably improved, but again, they still remain a little suboptimal, if I may call so, especially in self cycles. And there has been unprecedented advancement in technology for the past 4 decades. As you all know that embryo morphology is a very poor indicator of IVF success, if I may call, but that is again the most commonly used modality to select the embryos. So even the aneuploid embryos may have good morphology. I believe everybody understands what aneuploid means. I'm not sure about the audience. And ICSI is supposed to, carry a high degree of aneuploidy. People who are not destined to become parents as far as their genotype and their physical parameters are provided, but then still even somebody who is a azoospermic male not destined to be a father can become a father with the help of a technology known as ICSI, that is intracytoplasmic sperm injection. And in the meantime, we might end up transferring uh, genetic changes to the future generations also, especially if the offspring is a male. Is a male. So here we introduce the concept of pre-implantation genetic testing, which is practically inseparable from embryology now, because it is, if you look at the definition of a top embryo, they don't say that it's a nice blast and with good fourth grade of expansion and good true ectoderm. They have added the word euploid. In our country, we may not be doing all. I think maybe around 10% centers are doing PGT in our country, and maybe around 1 to 2% centers have got time-lapse machines. So, uh, but yes, I think there are specific indications for doing a prenatal genetic test, which you should do. And we should look for euploid embryos, especially in indicated cases and people who have suffered a lot of failures. They have a history of unhealthy offspring or advanced maternal age, severe male factor. These are the definite indications. And euploid embryos, if we are able to select, we can increase the chances of healthy pregnancy and also decrease the transmission of severe genetic disorders. So with PGT and especially with PGTA, we have this confidence of this intuitive appeal is there that we are doing the best thing possible in the world to give the patient a healthy conception, which again is a big question mark as far as if you review it critically, the PGTA technology. And it does give us a satisfaction of doing everything possible to minimize failed ET, miscarriage, or abnormal pregnancy. But whether this is the true scenario or is it an overstatement, that we will see, especially in the second session, when we will go on to review the implantation rates, the pregnancy rates, the cumulative CP pregnancy rates, etc. And then we will see whether it is actually benefiting or it is uh, just another technology. So PGT was first done by Handyside in 1990, and at that time the technology was known as pre-implantation genetic diagnosis. So in which we were using the FISH technology to find out to screen some chromosomes, but around 12 chromosomes were being screened at that point of time. And slowly and gradually, PGT has integrated into our ART practice. And we need a very thorough and extensive coordination between team of experts at the ART center, the genetic lab, and I think most important role is played by the genetic counselor. If you have a good genetic counselor, then you realize such an asset they are actually, because they can recommend the right tests which are to be performed for patient screening. They can determine the type of PGT which is applicable, and they can also counsel the patient, the pre-test counseling as well as the post-test counseling, as well as it does help the patient, to understand the risk and benefit of the test involved. And you have to quantify their expectations also. And, they are spending money and they are they become quite hopeful at times, but it may not always work. So a comprehensive counseling is very important, I feel. So as I told you, PGT is not new. It has evolved with time. It started with fish technology. Then there was a landmark article by Brook, which almost crucified the PGT, especially in the government setup. But yes, in private setup, things continue to evolve. And then came PGT, and that was known as PGT 1.0. Then came PGT 2.0, in which we had the iris technology, and we could screen the whole genotype. And ultimately, it evolved into PGT 3. PGT 3, it was still known as PGS, pre-implantation genetic screening, but now it is being known as PGT. And we have got three variants of PGT, which we'll go on to explain. And this involves trophectoderm biopsy plus NGS technology. If you look at the biopsy techniques, we were doing the polar body biopsy or the zygote stage polar body biopsy. And we were only screening for the maternal aneuploidies and issues. But then we slowly moved on to the cleavage stage biopsy in 2000, and in which again had its pitfalls. And ultimately, we have now the gold standard is a trophectoderm biopsy or a blastocyst biopsy at day 5, day 6 of embryonic development. So if you look at the technology, technology has also evolved. PGD, which used FISH technology, we were able to screen less than 12 chromosomes. But in 2008 came the RSEGH technology, and we could screen all the chromosomes. And now we have got the gold standard, which is the NGS technology. Little difficult to interpret for a layman, but yes, with time, you do learn. And again, the role of a geneticist or a genetic counselor is handy. But again, the technology is being plagued by mosaicism, which we will understand in a few slides from now. So PGT is basically classified into three types. PGT-A, that is which screens for aneuploidy. Formerly, it was known as PGS, pre-implantation genetic screening. We can screen for all the 23 pair of chromosomes. And, it's like looking in a library, and if a book is missing or a book is extra, you immediately come to know that is PGT-A. But again, if there's a page missing in the book, or it is folded on its own, then the technology comes to be known as PGT-SR or PGT-M. PGT-SR, in which there are structural rearrangements, or it detects translocations, inversions, deletions, disease such as Dijot syndrome, etc. Whereas PGTM is a single gene disorder. This is when PGD started as PGTM only, and it is used to detect known inherited disorders. So it's like an open book. In case of PGTM, the parents have the disease, and you can screen for the same. The common examples are thalassemia, sickle cell, Huntington's disease. If you look at the workflow of a PGT cycle, it starts with an IVF cycle. There's superovulation, oocyte retrieval, then IVF or ICSI, depending on your protocols. Embryo culture, ultimately you make a blastocyst, and we go for a trophectoderm biopsy. Then we go on to evaluate the genetics of it. We have to amplify the genome, and then we have to expose it to, nowadays most commonly we are using the NGS technology, followed by a cryopreservation, waiting for the report, and transferring the euploid embryo. So that's a very simple flow, but it's not as simple as it looks. There is a lot of techniques involved, a lot of human intervention, a lot of emotions are involved when you're practicing this technique. And yes, with biopsy comes the art of tubing also. So now I'm going to if you are setting up a PGT program, what all do you require? Before setting up a PGT program, you should have a very successfully running IVF program. You should be able to have an excellent blast deletion rate, an excellent vitrification survival rate. So second important is the personnel who are running the show, the gynecologist, embryologist, genetic counselor, and a cytogeneticist is desirable. And the third, something which is very important is there should be a very good communication between IVF lab, the clinician, as well as the diagnostic lab. So the integration of these services is extremely important, and a rigorous quality control program has to be in place to ensure that you're getting uh, you're getting excellent results, as well as you are able to maintain the data. So what are the infrastructure requirements of of a PGT lab? You need to have the proper licenses in place. You need to have the right people working for you, and you need to have the right instruments and equipment. So we'll just go on. This is a very basic lecture. So as per the directives of Ministry of Health in 1994, all the ART and IVF procedures and techniques, they are recognized as prenatal diagnostic procedures, and they are classified under the PCP Act. And under PCP Act, we can have three kinds of registrations. One is the genetic counseling center, genetic lab, and genetic clinic. So when you are aiming to set up an IVF facility and we are thinking of undertaking PGT services, then you have to get registered as a genetic clinic. And the law also lays down the mandatory requirements in terms of space as well as in terms of staff. And they say that a gynecologist with adequate experience and a radiologist is necessary. Embryologist again is necessary. Counselor is desirable. They have stated the area of 20 square meters with appropriate aseptic arrangements for a genetic clinic. But these requirements change from state to state, uh, since health is a state subject in our country. So different states will have different rules. So when you're applying for PCP&DT, you need to fill in the Form A, and you need to specify since they have mentioned many services, but unfortunately in under the various options they have, we do not have the embryo biopsy services for pre-implantation genetic testing. So you have to mention it clearly, and many of the CMOs and officers, they understand PGD and PGS more than they understand PGT. So you have to kind of mention everything to make it easy for them. And again, on the second page, we have to write that we require a license for embryo biopsy for PGT or PGT PGS. And your certificate of registration comes back in the form of Form B, which has to be displayed at a conspicuous place in your facility. Like this is an example of a center which was registered as a genetic clinic and a genetic counseling center also. And all the facilities were mentioned on the whatever diagnostic and therapeutic procedures they can do, they're mentioned on their license. And this is our license at Artemis. Initially, we registered for only genetic counseling center, but later on, when we started the PGS program, we did apply for an addendum, and we got this addendum in 2018, in which they recognized that we can do PGD, PGS, and NIP. So the certificate of registration is valid for 3 years, and it has to be renewed 60 days before it lapses. Now coming to the equipment, consumables, disposable, and culture media. Equipment is more or less overlapping between an IVF lab and a PGT lab. So we will just go on to the differences between the two. And if you look at so I'm displaying all the requirements, but I'm highlighting only the things which are exclusive for a PGT practice. So we have got a laser shot system, which is mandatory, a non-contact laser, which can be bought from any company of your choice. This is how the laser machine is stationed on the table, and this is how the pipettes look. The holding is as usual, but the blastomere aspiration pipette is a little different. If you look at the disposables, 70% alcohol now is outdated, but I've displayed it just because I have to tell that you don't use 70% anymore now. We're only using quaternary ammonium sterilizing agents, safe, Fertisafe, Embryo Safe. They come with various names. Whatever is easily available at your end, you can go for it. You have to wear a surgical gown, as well as your technicians also have to wear a surgical gown. There should be no foreign DNA coming into the area of work. If you look at the consumables, something which is extra from the routine is a blastomer biopsy micropipette. It can be 30 degree or 35 degrees supplied by any of the companies, and the inner diameter remains 28 to 32 microns. This is an example of a Cook aspiration pipette, but any company is fine. I mean, whatever is easily available and whatever you're comfortable with. So now trophectoderm biopsy has become a gold standard. Now nobody is doing a day 3 biopsy, and I really don't recall the last time we did a day 3 biopsy. So you've got fewer embryos on day 5 compared to day 3. So it reduces your workload and you're biopsying less embryos. So it reduces the cost for the patient. And we've got excellent vitrification results in cases of day 5 biopsy compared to day 3. And there we have got around 100 plus cells in a blastocyst. So even if you pick up 5 to 10 biopsied cells, it really doesn't affect the health of the embryo and the fetus in the future offspring. And the results are much more consistent compared to a single blastomere or maybe two blastomeres coming from a day 3 embryo. The detrimental effect on the embryonic health, as I told you, is minimal. And in case a rebiopsy is necessary, it is possible on the same day, but you have to wait for the embryo to re-expand and then take a rebiopsy. And also, it is a known fact that chromosomal mosaicism is much higher on day 3 embryos. It is almost 70% compared to a day 5 embryo, where it goes on decreasing. And is also said that as soon as the embryo implants, the mosaicism actually goes down. And there is some discordance between the trophectoderm mosaicism and the inner cell mass mosaicism. But these are bigger topics of discussion, which we'll take up in the next class. And the disadvantages of a trophectoderm biopsy are that you require an excellent culture conditions, and a blastocyst culture may be a little cumbersome for some of the labs, and you might lose some embryos on the way to day 5, day 6 embryonic culture. There's an increased risk of premature delivery, and with day 5 embryos, there's a long-term epigenetic effects which might come into play. The expertise required is much more compared to doing a day 3 biopsy. In day 3, you just have to, drill a hole and the blastomeres simply pop out and you take it and send it for culture. But here, you need more expertise. And then, as I told you, highlighted you that there might be some discordance in the ploidy status between trophectoderm and inner cell mass. And then with day 3 embryos, you might, if you have a lab functioning close to your center, they might give you the report within a couple of days, and you are transferring fresh embryos. But in day 5 and day 6 biopsies, there is no scope of freezing. There is no scope of doing a fresh transfer, and we have to cryopreserve the biopsied embryos. So what are the basic requirements when you're biopsying? Since I was also asked to speak on the technique. So when you're biopsying, the inner cell mass should be at an angle of at least 180 degree or at least 90 degree from the place you are taking the trophectoderm cells. So you hatch at the point where the two trophectoderm cells they join and the thickness is minimal. We hatch at this point and then we do the trophectoderm biopsy. So you've got the pulling method, which is applicable in some cases in which you simply pull, and as you pull, the cell junctions start becoming loose. You give them a few shots, and you can have around 5 to 10 trophectoderm cells, which you can send for biopsy. Or you have the flicking method, in which you catch hold of a few cells in the blastomer aspiration pipette, and we drag it onto a holding pipette, and the cells detach, and then you can send it for genetic analysis. So the timing of biopsy is also very important. When I started the practice of embryology, or when I started doing a PGT or embryo biopsies, there was a huge trend of drilling a hole on day 3. And then we had to wait for the herniation of blastocyst from on day 5 or day 6. And so the drawback is that rarely, or in some cases, the hatching point will be the same point from where an inner cell mass is stationed. So at that point of time, you don't know which part is going to differentiate into inner cell mass and which is going to differentiate as the trophectoderm. And if the inner cell mass is coming in way of your the hole which you drilled on day 3, you have to drill another hole and take the biopsy from the other side. So that's a big drawback. and there might be herniation of inner cell mass, as I told you, and the embryo has to undergo two manipulations or at least two holes, which might lead to degradation of the embryo, and the survival might be compromised. So we don't recommend drilling holes on day 3, although it makes life very simple. Many a times, you see that hole which you have drilled, trophectoderm is popping out, and you simply aspirate it and give it a shot, or just drag it over the holding pipette, and you have the cells in your for dispatch. So I'll just show you the other second approach, in which we hatch the trophectoderm cells or hatch the zona when it is fully expanded. So previously it is a day 3 hatching. Now we are hatching a fully expanded cell, and at least grade 4 of expansion is preferred when the zona starts to thin, and that is the point of grade 4 expansion. And at that point, you just give a slight shot onto the zona pellucida, like in this video you can see. This is a video which we recorded, and this allows simultaneously the zona opening and trophectoderm retrieval, and there is only one intervention which is involved. See, as soon as there is a hole drilled in the zona, you can either manually collapse the trophectoderm cells, or they collapse on their own. Wait for a minute or so, go inside, aspirate some cells. 6 to 8 cells are enough. Give it a couple of shots. So in 3 shots, you can do this biopsy. One at the zona and 2 shots on the top and bottom of the trophectoderm cells, and just flick it over a holding pipette, and you have the required number of cells. So when it thins out, just give 2 shots. Okay, now this is the third method in which the cells are popping out, and it's actually the easiest. You come on a day 5 or a day 6 in the morning, and you see that the natural herniation has taken place, and you simply aspirate these cells. And this is the pulling method, which we are using in the first instance, first method also. Just pull the required number of trophectoderm cells, give them a gentle hit with a laser shot, and send it for genetic analysis. So there was an article which was which studied the timing of trophectoderm biopsy protocols and whether they can really affect the clinical outcomes. And they said that the choice of biopsy protocol could impact clinical outcomes, and specifically zona opening during blastocyst stage with simultaneous biopsy. That is the second method which we showed. It resulted in higher survival after thawing compared to the approach that involves zona opening during the cleavage stage. So anything second and third method. Third method is a method of it's forced upon you by the nature. You don't choose that method. You come in the morning and there's a breach and the cells are popping out. But otherwise, by choice, you will go for the second method. That is a simultaneous hatching and aspiration of trophectoderm cells. Don't do a hatching on day 3. Once you are done with the biopsy, you have to cells for a genetic analysis, and you have to wash the cells and then place them in a PCR tube before you dispatch it to a genetic lab. So what are the requirements for tubing or loading? You require a laminar flow with incorporated UV light, which is mandatory, or you can have a laminar hood in a different room also, which is again, if you have the luxury of space, you can do that. Like in this lab, they have got 2 stations. So one they're using for biopsy tubing and biopsy, and then the other one they're using for freezing and basic handling. So you have to expose before you start off. You have to switch on the UV light so that all the DNA is lysed and there is no foreign DNA material present on the stage. And if you don't have an inbuilt UV light, you can procure these lights from the market, and you can just keep it for at least 15 to 20 minutes. And so this is a video of tubing which I picked up from internet. So I would like to show you. You have to pick up the cells from the dish, wash it thoroughly in drops like the previous you saw, and then you have to place it in the PCR tube. And all this while there has to be a witness, and you have to label the tube, and you have to sign as well as the witness has to sign. And you have to be very careful once you have biopsied the embryo, you've done the tubing, they should be going as per a number, and they should be frozen singly in cryologs or cryo devices, well labeled and witnessed also. So this is how the when you this is how it looks in a microscope when you do the tubing, and it's a very satisfying thing to see. When you push the trophectoderm cells into the PCR tube, and you see it very clearly, it's a very satisfying feeling that you've done the good job. So, what are the consumable supplies for the process of tubing? In older days, we were only using glass capillaries and mouth pipetting systems, but now with time, we have moved on to handheld pipettes, the denuding pipettes, and we generally prefer to use 140 microns of denuding tip. So when you generally the thought was that glass capillaries are not sticky, whereas the plastic ones, the denupates are sticky. But with time, we have shown that they are equally efficacious, and there is a way of handling the pipettes and the tips. And if you do it correctly, you can definitely manage very well with the help of a denuding handle, such as any company you can go for. But use 140 microns for handling trophectoderm cells. And there is the one thing I would like to tell you that for when you're using a stereo microscope and you rotate the mirror which is placed beneath the microscope, and there is a particular angle of the mirror where you see the trophectoderm cells very clearly. Always, you should know your choices, and whenever you work at a particular magnification where you see the cells clearly, as well as at an angle of a tilt of the mirror where the trophectoderm cells are extremely easily visible, always do that setting before you start off. Maybe you can start off with a very average embryo, do a test biopsy on it, and use that biopsy to keep everything in place and everything to your liking, and then you start off with a real embryo. This is how the mouth pipettes used to look like, no longer in use. And you should use filter tips, as well as this is a example of a stripper handle which we are using. A 60 dish is used to do the biopsy. It is same as the XC dish. So now coming to the personnel. There is no replacing an experienced embryologist who has consistently delivered successful biopsy rates of more than 90%. So the competence has to be assured. Recently, I visited a lab where there was a guy who had done 11 embryos. He had done biopsy for a patient with thalassemia, and the DNA was found in just 3 of the blastocysts. So actually, if you're not trained properly, it is criminal for you to take up procedures which require a great degree of precision as well as responsibility, I will say. And equally important is the role of experienced help and technical support. So when I go out for doing biopsies, I generally take my technician along, or somebody who I'm very comfortable working with, because somebody who can really witness, who can correctly label, ensure that things are running in the right way, is extremely important. We really can't afford to commit a small mistake. It will be detrimental to the patient's future. And a genetic counselor, as I told you, is a must, and you should be doing constant upgradation, attending most of the good conferences. And the successful biopsy rate is defined as number of fixed samples where DNA is detected upon number of biopsies performed. So if somebody is doing more than 90% of biopsies in which DNA is being recovered, that person is known as a good embryologist for biopsies, I would say. And it's a measure of the ability of embryologists to transfer the biopsy sample to test tubes as provided as by positive DNA amplification. You may be good at doing a biopsy, but you may not be good at doing a tubing. And it is actually a good idea to for the same person to do biopsy and tubing both, and do it. I mean, people who are very experienced, they do biopsy of number of embryos, they label the dishes, and in a go, they will transfer them to the tubes. So see for yourself what suits you the best. If you're a new person, you can maybe, do one embryo, then do the tubing, transfer it to the culture dish, keep it back in the incubator. But everything should be well labeled, well witnessed, and well documented. And after you're done with the biopsies, then you can go on to freeze the blastocyst. If you look at the documentation, it's something which is very important. And there are three forms generally which we fill, and Form D is the it's like a request form by the genetic, so it can be signed by the gynecologist or a pediatrician or a medical geneticist, in which all the details of the patient and basically what tests are required and why they are required. These two important details are mentioned. And Form F is for doing invasive procedures, and it is very clearly written that which procedure is being done is requested. And Form F stays with the patient and the authority, that is the PNTT team. Form G is another form which you fill, in which there is a signature of the pregnant lady, and it goes to the patient, the authority, and one copy remains with the genetic lab as well. So don't forget to fill these three forms, because if you don't document properly, it can come back to you anytime. So always do the correct documentation. Again, as I told you, labeling and witnessing is something which is very important, and the labeling should be comprehensive and practical for both the IVF and PGT centers. And there are two identifiers, maybe the name and the unique hospital ID, as well as the date. And you can either write with the help of pen, or you can paste a sticker. Electronic witnessing is the preferred option. And traceability should be ensured throughout the IVF as well as the PGT process, as well as extensive witnessing and documentation is a must. I will like to take up the ART law, then we can take a 5-minute break, and in the meantime, Sindhuja can introduce the MCQs to you. So if you look at the ART Act, which came on 20th of December 2021, it's a little vague in terms of the PGT, and it does specify in Form 1, where we apply that which investigations you need to do and which procedures you're applying for. But again, it doesn't very clearly define in which conditions you can do a PGT. It very vaguely it says that pre-implantation genetic testing shall be used to screen the human embryos for known pre-existing heritable, that is PGTM, PGT-SR, the heritable or genetic diseases, and when medically indicated. So it either discourages PGTA or it doesn't come out very clearly. And PGTA is something which is probably a little more common done in our country compared to PGTM and PGT-SR. And it very clearly says that no PGT should be done for sex selection for non-medical reasons or selection of particular traits due to personal preferences of the prospective parents, and to alter or with a view to alter the genetic constitution of an embryo. So it does lay down some conditions, but it's not a very clear outline of the. It doesn't offer a very clear scenario as far as the PGT goes. And in our state, Haryana, we have to take permission from the CMO before doing any PGT now. So and they take their own sweet time to kind of give us the permission, and then we start the cycle. Or if the embryos are frozen, then we have to just simply wait for them the permission to arrive, and then we can start the PGT cycle. So, Dr. Sindhuja, are you there?
Yes, sir.
So, can you introduce the MCQs now?
Yes, sir. The first six are each.
Yeah. So, it's like a 5-minute break, or it'll go on
Yeah, while
simultaneously.
she is doing the MCQs, we can also,
Take the questions, sir.
Yeah, please. And there is a little more slides are still kind of,
Sure,
left.
sir.
So we'll take up those slides also.
So I've launched the quiz. I request you all to attend. It's anonymous, so it's just to see how much you understood, and if you have any doubts, you can clarify it with sir. So, sir, can I ask you a question? Thank you so much for so far, and we're looking forward to hearing the rest of the presentation. So, there's a question on the chat box which says, does warming a biopsy blastocyst pose any risk to its viability and implantation?
Yeah, it does pose a risk. I mean, in unsafe hands, or can you hear me?
Yes, sir.
Because the picture is it's like a still picture now, and I don't know. Do I need to do something about that? Anyway, so it does pose a risk because it's a procedure where you're exposing the cells to unnatural conditions. You're taking them to minus 196 and bringing them back to 37. So and the proficiency of the embryologist is the key here. And just in case on doing biopsy, you feel that you've damaged the embryos in any way, then probably it's a good idea to wait for a couple of hours, allow them to re-expand, judge the biopsy, the biopsied blastocyst, and if you can grade it into the expansion, trophectoderm, and inner cell mass, all the three parameters, and you feel if it's a good blast post biopsy, then you freeze it. Otherwise, counsel the patient accordingly.
Okay. So, and after taking the biopsy, do you wait for the embryo to re-expand before cryopreserving it? Because there are mixed opinions now. So
Yeah,
previously we used to wait, and then now we just prefer
generally, yeah, that's what I'm saying. As a matter of practice, we don't wait.
Okay.
We don't wait, but yes, if we feel that we've not done a good job, then it's a good idea to wait, because then probably if it doesn't re-expand, you would not like to send that embryo for genetic analysis, as well as you would not like to, freeze it. Ultimately, if you don't get anything out of the whole procedure, then it's not a good idea, I feel. Because in olden days, we used to collapse the blastocele and then freeze the blastocyst.
Yes, sir.
And that actually gave us better results, because we have dehydrated the cell, as well as it re-expands much faster compared to a cell which is absolutely intact. I've seen that a biopsied hatched cell, I mean embryo, it re-expands much quicker in my experience. So I don't know what's your experience in Sindhuja, because I think you're also an embryologist. So
Likewise, so previously we used to wait
okay.
for the
So if
expansion.
you think that you've damaged the embryo during biopsy, then or you think, I mean, because when you're doing a procedure, you have that feeling, that you've done something wrong. At times, it's
Too
all
many
human,
data charts.
that 3% human error will always remain. So if you've done something which has affected the embryo's chances of survival, then I would recommend you to wait for a couple of hours. And the rest of the embryos, which you are very confident, you can safely, dispatch the trophectoderm cells, as well as freeze them immediately. Because even in hatching, while hatching, or laser-assisted hatching, we used to collapse the embryo and then freeze. So it's in a good state. There is no water. It's a good time to freeze the cell, the embryo. Sorry.
I think more importantly, post warming, the re-expansion after
Mm.
2 hours of warming before transfer, that will give us a fairly good idea of the blastocyst, quality
Yeah,
and
yeah,
this thing.
right,
So
very right. But
re-expansion after warming, I think, would also be an
absolutely,
important factor.
I
Uh,
agree. But again, just in case you feel that the embryo has been damaged due to any reason, any invasive procedure of biopsy, then it's a good idea to wait for
for
those
it to recover, yeah.
for the rest of the embryos. You can simply freeze them, and mostly it works out quite well. They're very standardized protocols. Timings are standardized. The technique is standardized in good hands. Usually there is no problem. It's a fairly simple thing, actually, but in simple things we tend to go wrong.
Okay.
That's true.
And
That's a
in
very
your
good point, sir.
experience, sometimes we have to do PGTA for a frozen embryo, for some reason, couple is having RIF and they have, couple of embryos left and we need to kind of look at PGTA for that. Do you find any added technical challenge in these embryos, or, is there any robust evidence that it reduces the success rate compared to, the biopsy of a fresh blastocyst vis-a-vis a frozen blastocyst?
So I have not included, but there are articles which say that it doesn't really make a difference if you're, kind of, because many times in some patients you will pool embryos. And so if when you pool embryos, then it's like you're freezing some and some are fresh. You might be having four odd blastocysts or four odd embryos from a previous couple of cycles, and one cycle you're doing fresh. So in my opinion, it really doesn't matter. I think we can get equivalent results. But what I do in such patients, I don't know. I mean, I'll take Sindhuja's opinion also on this. It will be a good idea to freeze a day 3 or a day 4 embryo, I feel, if you're planning a biopsy on a later date. Like if you're pooling, because I feel the more time you give for a embryo, because if it's a blast and you are warming a blast and doing a biopsy, so I think the level of intervention in a couple of hours will be a little more severe compared to warming a day 3 or a day 4 embryo and allowing it to grow into a blast, because there is some degree of I'll not call it healing because it's not an individual, but yes, some degree of homeostasis, and it might a day or 2 days might give it that advantage. It has its own share of drawbacks also, because the patient has expectations. The patient might be liking to freeze a blast in which there's a certain biopsy happening. But if you freeze day 3 or day 4 embryos, then they may not be able to develop into a blast. So those things are there, but again, it's a matter of convenience as well as choice of the embryologist. But I feel there are many patients who decide later when they face a couple of failures and they've got 5, 6 embryos frozen with us. They'll come back and say, "Why don't we do a biopsy? Why don't we do a PGTA?" A lot of, I think, bulk of our patients come like that.
Yeah.
So, but I feel that, Sindhuja, what is your opinion? I feel that because day 4 embryo freezing results are as good as a day 5 embryo freezing result. See, it's a very simple science. You are morula plus blastocele is blastocyst, right? And if you hatch the blastocyst, it'll shrink and it'll become like a morula. It's all cells, and so so you are converting a blastocyst into a morula and then freezing it. So you can very well freeze at a day 4 stage when you've got some degree of idea that genetic switch has taken place, and it is more likely to be a good blast. So it's not a bad idea, I feel, to freeze day 4.
Yes, sir. So we used to do a lot of day 4 freezing before, sir.
Yeah.
So I really used to prefer it too because, like you said, the blastocele fluid is less, there's lesser trauma to the embryo.
Yeah.
And I think it's one of the most resistant stages to cryo damage.
Right.
But
And
I
I
think,
feel it does help in, it does give it a little more strength compared to
yeah,
thawing a day 5 and doing a biopsy.
yes,
Thawing on day 4, leaving it for a day. And I think it gives into a little more strength in a very
yes,
layman terms, I will say.
yes, sir. But
It
I
could be
think
a
these
good
days
point.
patients are also very particular that they want to know how many blasts and how many, they want to know the plan exactly. Very
Yeah.
well informed these
Yeah.
days. So I
Yeah.
think a lot of those
Maths,
factors
maths
also
and
play.
science are different. So we
Yeah,
have
Yeah.
to give an
exactly.
approximate plan.
And especially when there is, advanced maternal age, or when there is decreased ovarian reserve, and we're looking at pull up, probably, it's a good idea that, we look at 2 or 3 cycles. Maybe, first 2 cycles, you can look at freezing at a morula stage or a little earlier. And then the final cycle, you can allow everything to grow and see whichever is coming and do a blastocyst biopsy.
Right.
But the opposite, sometimes we have patients who are very young and they have like surplus embryos, and then they land up in, surplus blastocysts, I would say, and they land up in RIF. And those are the group who would want to, take out those embryos and do biopsies at a later stage. So I think,
In young patients, I have seen that the embryos are more responsive. They are more resistant also, compared to the older females might have a little fragile eggs. So I think in older population, if there is a plan of pooling, I think a day 4 or a day 3 freezing will not be a bad idea. I think we can plan a study on this. I mean, with our share of patients,
yeah.
and
You want to take the poll? Is everybody done, Sindhu?
Yes, ma'am. I think around 63% have participated. So I'll just end the poll and share the results.
Yeah.
So we can proceed. Okay, so is the screen visible? So I'll
Yes.
just go through the questions quickly. So all of the following are mandatory before starting PGT services except. So the correct answer is license for genetic lab,
I think they got confused with
Yeah.
the all except. I mean, they
Yes.
thought whatever is
Yes. So
mandatory.
of course we definitely need
A
an
genetic
information.
clinic which you need, not a genetic lab. So that was the point I was trying to make in this question. Yeah.
Okay. I think that is a very nice question, sir. So the next question is the incidence of aneuploidy in women over 40 years is the correct answer is 80%. So majority there's a lot of mixed response. So now you know that 80% of embryos are aneuploid in women over 40 years of age. How many cells are removed in trophectoderm biopsy for PGT? 94% have answered correctly, which is 5 to 10 cells. Which of the following best describes the main risk of performing cleavage stage biopsy compared to trophectoderm biopsy? Um, the correct answer is higher incidence of allele dropout and amplification failure. So this also there is a mixed response. So now you know the correct
We've
answer.
covered this actually, we have not covered these things in detail there. I mean, maybe in the next class they'll come, but yes,
Yes, I think that's also intriguing for them to go back and read and also
okay.
attend the next
Yeah,
class.
yeah.
The chromosomal structure and structural rearrangements that are primarily tested using PGT-SR are both A and C. 95% have answered it correctly. All are indications of PGT-A except thalassemia trait in the sibling. Majority have answered it correctly. So I think whatever you've covered, everybody has
Done well.
answered it
Yeah,
correctly. So
they've
that's a
done well.
success, sir.
Except for the genetic lab, which I emphasized on, the genetic clinic actually. Yeah.
Yes.
So they've done well. They are attending.
Yeah.
Yes,
Yeah.
sir. Shall we proceed, sir, with the
Yeah, and yeah, now we can proceed. 1 second. Yeah. So this is my favorite slide actually, the objective of ART. So the creation of highest quality embryos and subsequently healthy children must always remain the primary focus of assisted conception or reproduction treatment. So with this comes the concept of genetic testing and PGT, in which we are trying to ensure that we are selecting the highest quality embryos and disease-free embryos. There is no monogenic disease, there is no aneuploidy and all. So that is where the integration of PGT comes with embryology, I feel. And if you look at the reproductive genetics, it's a branch which focuses on transmission of genetic information from one generation to another through sexual reproduction. It's a basic school definition, and it has a role in human health and family planning. If you look at the type of genetic disease, we can have basically three kinds of diseases: single gene, then there is a chromosomal abnormality, and then you have the multifactorial inheritance, which is most common. So, variation in chromosomal number. Aneuploidy is the loss or gain of a chromosome. So it is anything between 2n plus minus x chromosomes. So it is 2n minus 1, it is a monosomy, 2n plus 1 is a trisomy. Euploidy is anything which is a multiple of n, and practically diploid is considered euploid in our cases. A trisomy is a gain of one chromosome, as I told you, and most of these happen during the production of gametes through a phenomenon known as non-disjunction of gametes, in which the homologous chromosomes they fail to disjoin during segregation. This leads to the development of basically this happens in anaphase, and it is known as an anaphase lag, which results in a non-disjunction. And this is just a diagrammatic representation of how, due to non-disjunction and ultimately, fusion of gametes, how it leads to the formation of trisomies, monosomies, and this is a basic schematic representation of the same. We'll not go into the details of this. And this is a monosomy. It's a Turner's 45X. A trisomy, it's a Down syndrome 21 trisomy. It can be a triploidy, triple X, XXY, or XYY. And if you look at the incidence of aneuploidy, this was a question which I asked, and I should have taken up this slide before giving you the questions. So it is said that more than 50% of pre-implantation embryos are generally aneuploid. And in reproductive age, the aneuploidy in human oocytes ranges between 20 to 30%, and it goes up to 80% in women more than 40 years of age. And this is a documented data, so you have to be very careful with when you're dealing with elderly women. The problem is that they've got low variant reserve, and you do not have the adequate number of embryos to biopsy and to have a cost-effective result. So either you go on pooling and multiple cycles, which again is a thought which can be debated. To pool or not to pool is again a thought, and I believe in some cases you can very well transfer because the individual chances of an embryo implanting with or without testing, they do not change. So if I've got a euploid embryo in the first cycle, I will like to transfer it. So it's a thought. It's a thought. So we can discuss it with Dr. Vasundara and Sindhuja. So aneuploidy increases with age and implantation goes on decreasing. It's a very well-known fact. I'd also like to tell you about deletions because we are going to deal with PGT, SR and all. So you should have basic idea about the composition and arrangement of chromosomes. So in this particular chromosome, this is on the left are the normal chromosomes, on the right are the abnormal ones. There's a deletion of D gene. So it's A, B, C, and E comes. And then there's a duplication of BC in this one. So it's known as duplication. Inversion is when there is an inversion. So ABCD, it becomes ADCB. So there's an inversion of CD here. And translocations in which a couple of genes or three odd genes will go on and they'll attach the other chromosome. It can be reciprocal or it can be otherwise also. So in this, it's a reciprocal translocation. In Robertson translocation, it is only in telocentric chromosomes. The fragment, which is the short one, is usually lost because it doesn't have the capability to survive, and the bigger one survives. It can lead to diseases which are documented. So when again with this introduction again now I think it's easy to understand structural rearrangements. It can deletions, translocations, inversions, and PGTM is a single gene disorder. PGTA, and we'll be taking PGTA in detail in the next class. And just to introduce PGTA, it was marketed as a very mature technology by companies such as iGenomics when they launched the services, and they underestimated the loss of potential implantations because in PGTA it's a double-edged sword. So you have to do it assess it very carefully, and the companies, they tend to overstate the benefits, and they tend to overstate the accuracy, and they do advocate its application in almost all the cases. So the data they published, they said that the implantation rate goes up by almost 22% in age group of 35 to 37 and 38 to 39. And which was not the case because this was not evidence based. And a similar publication in the same year, a couple of months later, they said that the implantation rate with the PGTA, it did not improve significantly, as well as the live birth rate also did not improve significantly. So the genomics data was probably flawed. And there are specific indications for PGTA: advanced maternal age, previous pregnancy with chromosomal abnormality, repeated implantation failure, repeated miscarriage, and severe male factor. So these are the 5 indications in which you should do PGTA, and no other indication is there. But people like to do it in the first cycle itself because it's a world where we are, we want fast food, and we want a Blinkit or a Swiggy and a Zomato and very quick delivery of whatever we require. So, and PGTA does rank the embryos in terms of euploid, low mosaic, and high mosaic, and those. So PGTA can be used to rank the embryos if you've got a certain good pool of embryos. And it is believed that PGTA decreases the time to pregnancy. But again, a lot of research has gone in, and it has not been shown to be of any major effect in younger individuals less than 35 years of age. And in more than it's actually the chief utility lies for more than 40 years of age group, in which unfortunately we at times will not have much embryos to transfer. So what have been the game changers for invasive PGT? It's a two-factor biopsy, as I explained you in the previous session. Increased survival after vitrification. Again, vitrification has been a game changer in the practice of IVF, I will say, for many years. No other technology has influenced IVF and ART as much as vitrification has done. And everything is revolving around vitrification. If you look at fertility preservation, you look at PGT, you look at anything, I mean, all freeze technology, you look at anything, and everything is centered around cryobiology and vitrification. So, vitrification, a good, excellent vitrification program is a must for you to survive. And now with the help with RACGH and post RACGH, whatever technology has come as well as the genetic analysis is concerned, we are able to evaluate the ploidy status of all the 23 chromosome pairs. The PGS 3.0 perfectodome biopsy plus NGS. That's the norm nowadays. So there are obviously with everything can't be good about the technology. There is something which we are worried about. It's the cost that in a poor country like ours, many people will fit in the category of the 5 indications which we have explained, or the indications for PGTM and PGTSR. But can they really afford it? And if they can afford it, what's a cost-effective way of carrying out PGT in such patients? We should not overdo, neither we should underdo. Then people, skilled personnel who can actually do a biopsy, and as it showed you in the beginning, and with a 90% of recovery DNA recovery rate in the biopsied cells. And then we are also concerned about the impact on embryo. So if you take out some trophectoderm cells, will it have a negative impact on the embryo? You are also exposing the blastocyst to laser hatching, so it might again have some degree of negative effects. The biopsy technique in itself is traumatic, and then exposure to vitrification, prolonged culture, epigenetic changes. So many things play a role. Then again, this will take up in the next session. What is the predictive value of PGT and especially PGT-A? Because PGT-M and PGT-SR, they are like, missing pages in a book. So you put in the page and you get the answer. But again, PGT-A is something which is a big debate. False positive results they are actually, you see false positive results in almost all the PGT modalities, and that is why it is recommended that you should follow up the PGT with prenatal test also, because PGT results are quite diagnostic, but then they're not confirmatory. Effect on neonatal outcome, again, matter of concern. And as I told you, the effects of epigenetic changes and other effects of extended culture, like high birth weight babies and other epigenetic changes. So, is PGT cost effective? So it is said that the total cost of infertility care is total cost to either attain a delivery or exhaust the available cohort of embryos compared to the cost of cycle without PGTA. So you either, if you have got 10 embryos, you do a double embryo transfer in your center, or you do a single embryo transfer. So as many transfers without PGTA compared to, obviously you'll have some reduced transfers with PGTA, because some embryos will be absolutely ruled out for transfer, high mosaics and aneuploids. So you might end up with just 3 or 4 embryos which you have to transfer. So you have to compare the cost. So it is said that in Western countries, they say that if you've got 2 or more blasts, you should screen the blastocyst. But I feel in our country, this number should be at least 4, because 2 is a very low number in our country, because affordability is definitely an issue in our country. Because we come across many patients routinely, and if they've got 1 or 2 blasts, they'll say, let's transfer, let's not invest on the screening techniques. Mastering the technique, it's not difficult for an experienced embryologist. I think there are a lot of articles which have shown that. I've not quoted, but if you want, I can quote in the next class, in which they've shown that the embryologists learn the art of biopsy quite quickly, and their results are comparable in different hands also. So there are a lot of articles which say that RCT was done in 2013, which said that trophic biopsy may be done without adversely affecting the reproductive potential of of an embryo. This is again a very encouraging study. If you look at the neonatal outcome, trophic biopsy looks to be a safe approach, as the neonatal outcomes from biopsied and unbiopsied embryos were comparable. But there was a high risk of gestational hypertension, but it again may have a predictive effect on premature rupture of membranes. So it's like a mixed kind of results, but more or less it's a safe technology if you look at the neonatal outcomes. Application of laser again, there have been many studies and they say that there have been no adverse effects on in neonatal outcome as far as the use of laser is concerned. Two special categories I wanted to highlight, like Dr. Vasundara was asking. In cases of repeated freeze-thaw cycles, the blastocysts biopsied and vitrified and warmed twice have reduced clinical outcomes compared to blastocysts which have biopsied and vitrified warmed once. So if you do it repeatedly, the implantation potentials are definitely compromised. And you may claim that you've got very good hands and your experience is amazing, but then still there is some degree of natural insult which comes with invasive procedure such as a biopsy as well as with vitrification, which plays on the implantation chances. If you look at the technology, previously the companies never used to accept the embryos which are coming from IVF, blastocyst, but now they have started accepting. But again, the norm is that ICSI is preferred as a method of fertilization for PGTA cycles, because if some degree of sperm DNA comes, then it might lead to a mosaic pattern, and which is not desirable. So if you're doing an IVF embryo, you have to take care right from the day one. You have to denude it thoroughly and remove remove the sperm completely. And so that's also something which is not very routinely done, IVF fertilized embryo biopsy. So optimization and validation of embryo biopsy, vitrification procedures, and genetic testing procedures at the lab are crucial in determining the success of PGT cycle. So embryo biopsy, vitrification, and the lab you choose, that's again very important. Your different lab, since there is a huge difference in the labs who are doing IVF, similarly, there's a huge difference in the labs who are doing genetic testing. So choose your lab wisely. Talk to the people. If you think they're confident, then go ahead with them. So the goals of PGTA are improve pregnancy rates and implantation rates, decrease time to pregnancy and emotional burden, decrease miscarriage rates and risk of abnormal offspring, as well as you can safely go for a single embryo transfer or a dual embryo transfer, so it decreases the risk of multiple pregnancies. But again, anything which is more than one embryo transfer can lead to a multiple pregnancy. So if you're targeting a single pregnancies, transfer just one embryo. In the poorest of poorest prognosis, transfer just one, because embryos are there's a funny interaction between embryos and endometrium. They do implant at times. So mosaicism is something which I wanted to cover, but I think we'll take this up in the next session. It's a very detailed topic, and it really plays a huge role in determining the success of PGTA. And there's a lot to debate on mosaicism, so it will be a good idea to take it in the next session. With the presence of two or more cell lines with different genotypes in the same individual, that's mosaicism. And we will continue the session in the next class whenever Dr. Vasundara gives us the opportunity. And before I end, I want to introduce our academy, the Fertilis Academy. And we are doing a course on immunogenetics. As a part of the course, we do preview classes. Yesterday, we have done a class on why euploid embryos fail to implant. And on 20th of August, that is next Wednesday. The date is wrong on this flyer. I'm sorry for that. On 20th of August, we are having a class on RPL versus RAF, and in which we'll be taking up the immunological aspects of recurrent implantation failure and recurrent pregnancy loss. The date is 20th August, that is next Wednesday, 5 p.m. onwards. And this is a preview to the course on reproductive immunogenetics, which starts on 25th of August and goes up to 5th of September. It's a four-day program. It might spill over for another couple of days because the topics are extensive. So we might have a 5 or 6 day program because it might spill over. So with this, I end my presentation and I invite you to join our course on immunology, immunogenetics, and you can register through the Fertilis Academy website, the Fertilis Academy. Thank you. I'm stopping the screen now and I'm open to questions if there are any.
Thank you, sir. So would you prefer me sharing the poll now or in the next?
Yeah, please do that because let them
Okay.
spend some time here.
So I think there are a few questions, right, Sindhu? Can you just take them?
Yeah.
Sure. I'll just launch the quiz. Yeah, I've launched the quiz.
Yeah.
So, okay. So what's the minimum number of cells to be biopsied for an adequate result? I think you've mentioned 5 to 10 cells.
Yeah.
Would
Yeah,
you like
it sells, and the
to
funny
add
part
anything
is
to that, sir?
I'll just an anecdotal thing which I'm actually talking to a lot of geneticists also, and they say that they get so this is a very broad range, and each lab is sending them different cells. So we will also discuss the importance of the number of cells sent in the next class. So it actually gives
Okay.
everything comes out as a percentage, right? Numbers
Hmm.
and all. So the denominator changes with which each biopsy. So we'll discuss it in the next session. But yes, 5 to 10 cells is the right answer.
Okay.
6 to 8 maybe is a little more conservative.
Hmm. Yes, sir. So has anyone had personal experience of finding out a genetic discordance between the trophectoderm and ICM of the same embryo? What's the percentage of discordance? There's a lot of literature on this, but personal experience, do you
It's
have
not
any personal?
I think it's the discordance is not a great deal of discordance, but there have been animal studies. Obviously, you can't do a human study on it. And the discordance is less than 5%. I'm not recalling the exact percentage, but we'll show that in the next session. And I think it's 3 to 4%, if I remember correctly. That's the discordance which we've seen in animal studies.
Okay.
But again, I'm not very sure, but I can find out if it's required now. I can pull out from one of my slides.
What is your call for NIPGS? Is it worthy or not? It's a very broad
I think IFS is given
Well,
a
yeah,
statement now.
statement that
I
we
think.
cannot.
it's a consensus given by many bodies actually. It's ACE, IFS, SR. They have discarded. They've actually, they feel that it's no good. But if you talk to people from West, they really are
So, but do you not
talking
recommend it
huge
even in
about.
situations where you have,
Sorry.
sorry to interrupt you, sir. So even in situations where, you have, it is mandatory to do PGTM for a patient
I,
because it's absolutely indicated. The patient only has a 5 cc blast or a 4 cc blast. In such situations, what do you do, sir?
so PGTM, I'm not very sure. Can it be done with NIPGS? I'm not very sure. Sorry for my
No,
ignorance.
it cannot be done.
So PGTM, maybe it's in fancy stage and it's evolving. But
Hmm.
once a lot of applications come, see it's the future. This I can see, but like even big companies, big corporate houses have given up on NIPGs. They did it for a couple of years. They found that it's no good. They're not getting the
Hmm.
right answers as they were getting in invasive PGT. So, if you look at PGTA, the funny part is that there are a lot of pitfalls of PGT, invasive PGTA also, right? And it's not a
Hmm.
gold standard by any means. But the funny part is that you are comparing non-invasive PGT against something which is not even a gold standard. You're getting my point? Something which has an
Correct.
accuracy of 70-80%, and the other one has a concordance of 80% with a modality which has a accuracy of 70 or maybe 80%. So it actually the accuracy goes down. The predictability also goes down because you're comparing with something which is not the gold standard, which is not 100%, which is not very specific.
Correct.
For the benefit of all, you did mention about how to make the lab ready for your PGTA.
Yeah.
So in a busy lab, the ideal scenario would be, you have two different labs. One is for PGTA and other is for your routine lab, IVFs and XCs. And many of us do in one single lab. So in that scenario, you have cases, you have PGTA on the same day. How do you manage to do the biopsy, and how do you manage to do all the cleaning process, making the lab ready? And also, what is your protocol that you follow in your lab prior to PGTA, just from the basics to this, so that all of us can benefit out of this?
So usually, let me just frankly admit that it's very difficult to carry on genetic testing in labs which are very busy. Anybody who is doing more than 5 odd cases in a day and in a small lab and working on the same stations, so you should have at least two working stations, which will help you. If you are having that kind of load, I think if somebody is working in a busy lab, most likely they would have got two laminars and two stereo microscopes, and different station for denuding and egg sorting, and another one for cryobiology. So
I think there's some interruption in your connection, I think. Sindhu, can you hear
together
him?
in tandem.
Yeah.
So that's how the eventually and
Now I
with his
can.
work. So if you can time it, but again, you can't time the expansion of a blastocyst. So at times it becomes very tricky. Some of the blasts have expanded. For some you have to wait. So it's
Stuck again, no?
Yeah. There's some connection.
I think
You want to take the...
sir has
Ah,
to.
yeah. There was some connection issue there. Yeah. Can you unmute, please?
Should I share the poll list results, ma'am?
Yeah, please.
I was actually telling you that it's very difficult because I work in a lab and they're doing almost 7 to 8 pickups, maybe 10 pickups in a day. So it becomes extremely impossible to do the biopsy in such a scenario. So plan things, try to wind up, and people who are doing 7, 8 cases in a day, they would not like to avoid their cases on any day, and they would not like to work with your comfort levels. Let me be very honest. So you have to work at the end of the day only. I mean, with biopsies and other procedures. You need staff for help. So and they also need to go home. So it's at the back of the mind, they should also be relaxed. You can't expect them to witness properly if they are under some kind of stress. So a lot goes into biopsy. Sometimes they have not expanded, and you've done a few biopsies in the morning, and then you again see in the afternoon, and you feel that by evening you should be able to do the biopsy. So it's a very exhaustive procedure, actually, and that is why some people who have got an in-house machine, it's very good. Those who do not have an in-house machine, at least book the machine for 2 days. Never book it for one day, because one day might not be able to solve your expansion issues. So always book the machine for 2 days if you're doing biopsies.
Can we take the poll answer, Sindhu?
Thank you, sir. I think I'll end the poll now, and I'm sharing the results. Okay, so the first question was, what is the primary purpose of genetic counseling in the context of prenatal genetic testing? 74% have gotten it correctly, saying explaining testing options, implications, and supporting decision making. So the others, please understand, it's for all these reasons. And what are the indications of PGTM? 89% have answered correctly, all of these. Mosaicism in PGT results means 88% have answered correctly that the embryo contains 2 or more cell lines with different chromosomal complements. All of the following are false regarding the accuracy of PGT except 58% have answered correctly. That is, a confirmatory prenatal diagnosis is still recommended. What is the most critical reason for performing whole genome amplification in PGT workflow? 83% have answered correctly, to generate sufficient DNA from limited biopsy cells for downstream testing. A couple has Robertsonian translocation involving chromosomes 14 and 21 in the male partner. Which embryos in PGT-SR would be considered for transfer? 57% have answered correctly, which is balanced translocation carriers and normal karyotypes. Which clinical scenario provides the least justification for PGTA according to current ESHRE guidelines? The correct answer is recurrent implantation failure in young donor egg. So I think that's a learning point for everyone to go through the guidelines. And what is accuracy rate of PGT-M? 98 to 99% is the correct answer. Which sample is required for PGT-M and PGT-SR? Trophectoderm biopsy is the correct answer. And name the current sampling method used for NIPGTA testing. It is spent culture media.
Culture media.
Yes, sir. So I think most of the answers, everybody has gotten it right. And I think everybody has
quite impressive. Yeah. You've done well.
tried to assess and analyze. And very interesting questions, sir. Thank you. Thank you for that.
Thank you so much for being with us for an hour now, and more than an hour, I would say, on a weekday. And thank you so much, Dr. Sarabpreet, for accepting to be part of this academic venture and masterclass series. And we are extremely thankful and grateful to all the delegates who are present here and being very interactive. We would share the feedback forms with you, and we will also send the email certificates soon. Thank you so much, and see you soon in our next masterclass series. We will be announcing it shortly. Thanks, Dr. Sindhuja. Thanks, everyone.